It funded it with a fee that insurance companies had been paying to support a high-risk pool. You no longer needed a high-risk pool for individuals if you had a different insurance system. The marvelous powers of executive orders, as Senator Adams mentioned. It's not the best way to do government, but when you have a Democratic House and a Republican Senate that was going to complicate things, the Beshear administration thought better just to do it by executive order. This order was under a 1996 law on Medicaid that said the state shall seek all Medicaid money possible. And that basically gave the green light to expand Medicaid without any kind of legislative involvement. Now, Senator Adams was incorrect when she said that the legislature can't do anything about it. The legislature could amend that law. And, as I'll discuss later, I think certain Republican legislators have indicated that they are going to take the wheel no matter who is elected governor this fall. It's interesting to note that the old threshold for traditional Medicaid in the state was 69% of poverty, now 138%. We doubled the income that a household can make and still be eligible for Medicaid. And what about all the people who didn't have good policies? About 280,000. Most of them got extensions for a year or so from the insurance department. This is part of the national hue and cry because, after all, the president did overpromise. He said, you like your plan, you can keep your plan. Well, no. Some people didn't have good plans, so they couldn't keep them. So what were the governor's reasons for the expansion? It ought to be common sense that if you bring more people into the health care system, then the state will wind up being a healthier place. Now, certain critics of expansions will point to a study in Oregon which showed that a limited expansion there didn't have any effect on health status. But that was a fairly short-term study. And there was another study of 3 different states done by Harvard that showed there was some impact. I think it's just common sense you're going to have a long-term impact on people's health and the health status of the state. And that ought to help us attract and retain jobs. You know, when you have a lot of counties in this state where employers can't find enough people to pass a drug test, then you know we have serious health issues out there. Now, this is a point of contention that really should have been discussed in the earlier panel, but I wasn't going to inject myself into it. A study says the expansion is going to pay for itself. You bring a lot of people into the healthcare system. The healthcare system has to hire people. Those people pay taxes, and we use the tax money to fund the expansion. Problem is, it's hard to track specifically what jobs are involved. And we'll talk a little bit about that later on. But that was the governor's reasoning. Meanwhile, some other folks used another part of the PPACA to create the Kentucky Healthcare Cooperative, nonprofit insurance company, so that insurance companies would have some competition on the Connect exchange. Well, the Connect enrollment was a lot heavier on Medicaid than expected. As Bill Wagner mentioned, about a third of the people who were eligible for subsidized insurance, that's basically from 100. Those who did enroll tended to be sicker. And that means insurance premiums went up. The co-op sold 3/4 of the plans on Connect, and it's had to raise its rates an average of 25%. It lost $50 million, more than any other of the 22 or so co-ops created. Alexa, this is not the current version. But if you look closely at the study, a lot of that money, or a good bit of the money, goes to local governments. And I tried to look at this sort of like a legislator would, like Senator Julie Rocky Adams would. What are we paying out and what is coming in to the state budget? Now, there are a number of savings that the state has had because of the Affordable Care Act. It doesn't have to pay a lot of things it used to have to pay for. I won't bore you with the details of those, but let's look ahead at what might happen in the future budget years. Go on to the next slide, and then the one after that. Keep going. One more. One more. Nope, that is not the current version as I saved it. Suffice to say that the Medicaid expansion, according to Deloitte Consulting LLC, will pay for itself in the next budget, but just barely. And then the state will have to find some money. Now, one thing the Deloitte study did not do is estimate the positive impact of lesser health expenses because people are getting healthier. The state actually tried to get Deloitte to include that in the study, but Deloitte said, it's a crapshoot. We don't have any way of estimating that. We're an accounting and management firm. We deal with real numbers, stuff we can prove. So we really don't know, but when people start throwing around a lot of figures about what the expansion is likely to cost, it's a lot more complicated than you might think. Senator Adams was correct when she said the cost would be about $250 million for the next biennium. She didn't specify a time period, but looking at the figures, I think that's what she meant. Trouble is, you can't track the money coming in from the extra jobs. Jack Conway has asked the governor, can't we track this money? No, we can't really track it. The other big result, and this is sort of the headline result that you would want to write, I think, about the impact of the PPACA in Kentucky, is we reduced our uninsured population more than any other state. And we had huge decreases in some counties. This map shows the percentage of the population that was uninsured. This is based on estimates with census and CDC data. You can see a lot of counties were above 17% uninsured, those that are in red or dark red. Look what happened. That's an amazing change. Let's go back again. Will it go back? Okay, that's what it was. The colors are a little hinky. And this is, okay, that's what it was, and this is what it is. I don't know what happened in Todd County, but that was the only county left in orange, the only county that was above 14% uninsured. People took advantage of this program in a way that was not expected. Now, I have a sneaking suspicion that the state and Deloitte conspired to say, yeah, it's going to be a gradual increase. You know, they didn't want a hockey stick that was going to make people scared. But people knew it was available, and people enrolled. If you want county-by-county data on the Medicaid expansion, the state has something called the Medicaid Dashboard. A simple Google search will find it. This will show you how many people in your county or any county signed up for Medicaid expansion, and it will even tell you how many people got a screening for asthma or breast cancer or colon cancer, free screenings as a result of the program. That's where the rubber meets the road. Those are the stories that really need to be told by journalists covering this. Who's benefiting? You know, we hear a lot of the political debate from advocates and critics, but we hear very little from people who have been helped by the program. We no longer hear much from people who were hurt by the program because their insurance wasn't up to snuff. But that's still important in the public policy debate because that's a motivator when it comes to voting. So use the Medicaid dashboard to get that local data. Here's an example of the screenings. It's pretty amazing. You put some really raw numbers on it. You know, how many people? Over 50,000 for breast cancer. Almost 80,000 for cervical cancer. 35,000 for colorectal cancer. Physical exams, 64,000 people, went up 187%. This is an increase over the previous year being paid for by Medicaid. And preventive dental exams in a state that has awful oral health also more than doubled. Now, the downside of that is the Kentucky Health Issues poll taken by the foundation showed that a bunch of people said they still didn't get health care or they delayed it because they feared cost increase or just cost period. And this even included people who were on Medicaid, not just those people who are eligible for the subsidized private insurance. So this to me shows a problem in adapting to the new system. And as I think Sheila Schuster mentioned, these people basically haven't had insurance before. They have to learn how to be insurance consumers and how to be, responsible patients. What about the jobs? Senator Adams mentioned a loss of 7,000 jobs in Kentucky hospitals. That's true. But in 2014, when the act took effect, you can see a jump in employment by physicians' offices and other ambulatory care. Also an increase in nursing and residential care. And these are figures from the U.S. Bureau of Labor Statistics, compiled by Dr. Paul Coombs at the University of Louisville, who I would call a skeptic about the Affordable Care Act and its implications. But these are good, reliable figures. I think generally you can say there has been an increase in jobs, which the Deloitte study predicted would result in more tax revenue to pay for the expansion. We're not sure exactly, if it's on exactly the right track to do that, but the early indications are fairly good. The expansion has brought more than $2 billion into the state economy, about $1 billion of it for hospitals. But Medicaid only reimburses at 82% of cost. So the hospitals say we're losing money on every Medicaid patient we treat. Meanwhile, they're losing the disproportionate share payments that they have received because they treat a disproportionate share of Medicare and Medicaid patients. The Medicare dish is gone, and the Medicaid dish will begin to disappear in, I think, 2017. It was supposed to disappear early, but because they raised such a hue and cry, it's been delayed. They also say they've got more bad debt accounts. They've got less uncompensated care because, there's Medicaid to pay the bills, but because people have higher deductibles and co-payments and can't pay them, they've got more people to chase to get the money. State officials like to say, well, 80% is a better reimbursement rate than 0%, which is what your uncompensated care reimbursement rate was. You weren't getting anything for that. Pretty striking graphic here. This is from the Foundation's snapshot. They're taking a quarterly snapshot of the effect of the act. Very big decreases in uncompensated care at hospitals. And rural and urban are separated here because rural are really more affected. Now, the hospitals say, we're still getting less. We're getting this extra revenue, but we're not making it all up. Frankly, this varies from hospital to hospital. And each hospital's finances aren't all that public. They have to file an annual report with the state, but you can eventually get the numbers, but it's hard to get current numbers. I would refer you to the Code Blue report by the Hospital Association. It's something of a polemic. It's a lobbying document. It's an interest group looking for help, but there are good references there. And it's the best case that the hospitals have to make for their issues. And you could also refer to the state auditor's report on the financial health of rural hospitals. He looked at 44 of the 66. That many were willing to show their books to him. And he found that about a third of those he looked at were in financial difficulty. There was an ad early in the governor's race that said, there's a crisis in hospitals because of Obamacare. Well, that's not the main reason. I think hospitals' main problem has been managed care and adapting to that system and the kind of treatment they've received from managed care organizations and the state. Managed care organizations, except for Passport, are subsidiaries of insurance companies. They act like insurance companies. They get a set fee for every patient in their network. Patients choose their network, and they get what's called a capitation fee. So they have this incentive to limit the expenses. They're going to get X dollars. The only question is how many dollars they're going to pay out. So they try to limit expenses. And the hospitals have rightly complained about a lot of the aspects of managed care: slow pay, no pay, reduced pay, too much paperwork, too many different pieces of paperwork to deal with. So the state has responded to these complaints and revised the managed care contracts. They went into effect July 1st. And we hear fewer complaints now from hospitals, but no government program is ever completely satisfactory. They are inherently inefficient. So you still have to keep working on these programs to make them effective. So these changes were too late for some hospitals. We've had a couple close in Fulton and Carlisle. As I mentioned earlier, the problem really is with rural hospitals. They get 72% of their patients who are Medicare or Medicaid, and some of them are now joining groups. They can't really stay afloat on their own. Latest two examples are in Horse Cave and Flemingsburg. I mentioned the auditor's report. Some of these hospitals have management issues. You know, they're true local entities. You got kind of a buddy system that goes on between the board and the administrator. I know one hospital in this state that would sell to any number of buyers, but they want to say, you've got to keep the administrator. Well, the administrator is part of the problem. Those kinds of management issues really need to be looked at by journalists at the local level. If you hear of a local hospital having a problem, look into the board and management. That could very well be part of the issue. Now, most of these hospitals are owned by larger groups, and their boards are just advisory, but sometimes, you know, those advisory board members know things that might be helpful. You know, the companies tend to co-opt them so that they'll, you know, put out good PR for the company, but they're still worth talking to. Not enough local news media take a close look at what's going on at their local hospitals. They're kind of like me. Oh, it's healthcare. It's too complicated. Don't want to do that. We got to do that. You have a question?
That hospital is a private corporation. How do you get them to open up that information?
Well, you can go to the reports that they have to file annually with the state. And, you know, the Centers for Medicare and Medicaid Services have information about what they give to hospitals. And as I will mention later, there are also places you can go to see what quality of care hospitals are giving too. You know, you put the heat on hospitals about the quality of care they're giving, and they will begin to respect your inquiries. And it may take them a while to get used to being held accountable, but in many communities, that's the most important institution that needs news coverage. So some of them have adapted well to the changes and others have not. Generally, I think if you're in a group, it's easier to adapt. I mentioned you can look up how hospitals do on performance. There's a couple of provisions in the law that says if you let your infection rate go up, then we're going to cut your Medicare payments. And if you admit somebody within 30 days without some kind of, you know, for the same condition, then, and your readmission rate goes up, then you're going to get cut as well. Kentucky is relatively high in the country on readmission rates. Those are a couple of metrics by which you can judge the performance of a local hospital: readmissions and infections. Then there's something called Medicare Compare, where patients get online and they rate care that they received from their hospitals. Alexa, I think I just put too much on these slides. It's taken a while to... All right. So how do we address these issues? What in the political and journalistic system do we have to look ahead here? Well, Congress is in gridlock about all this because all the Republicans want to say is repeal, and all the Democrats want to say is protect us from repeal. There are plenty of things in the law that could be improved, and I'm not going to go into it in detail because it's a federal law. It takes federal action. This is a state-focused kind of thing. But it's the kind of thing that will be debated next year in the presidential election and the congressional races, and one would hope that by the time we get another Congress that we can get off dead center. The problem of not enough healthy people enrolling might improve because the tax penalty is going to increase. There's also a chance that word of mouth will help this. Well, I got coverage for the first time, and I'm really glad I got it because I had this health issue, and I don't know what I would have done without it. Now, in 2017, that's when the next Congress comes in, the states are going to get a lot of flexibility. You're going to see Obamacare change from state to state. They're going to be able to change benefits, subsidies, mandates, as long as they can show that health care is still just as accessible and as comprehensive and affordable, and that these changes won't add to the federal budget deficit. In other words, we're not going to throw the cost off to the federal government. It's going to be real interesting to see what kind of waivers that states apply for. And this may actually short-circuit anything in Congress. Congress may say, well, let's let the states, deal with this thing. Now, I jumped a slide. All these issues are part of the governor's race. Not all of them, but some of them. And I mentioned the ad. Let's go to the chart and see where the two major candidates are on the big issues. This really is the news peg for writing about these issues. The election is in 6 weeks, and it's a very important election. You have a Democrat who is essentially running as an incumbent because he would largely keep the direction of the current administration. You have a Republican who pledges to shake up Frankfurt, maybe turn it upside down. And even some Republicans are nervous about that. But let's take a look at the positions of the candidates. Matt Bevin, the Republican, disputes the Deloitte study. He just says, it's nonsense. He has this line which says, if we're making money from putting 25% of the population on Medicaid, let's just put all the population on Medicaid. That's an insult to people's intelligence. We're putting people on Medicaid so they get covered. Everybody else is already covered, or the people who want to get covered. But it's one of these lines that appeal to people who are suspicious of government programs and government-funded studies. If Matt Bevin comes to your town and utters that line, you must hold him accountable for it and say, that doesn't make any sense. We're talking about getting people covered. Why don't you believe the study? I'm suspicious of state-funded studies too. But it's all we've got. And Deloitte is an internationally known consulting firm, and they resisted the state's effort to put in a lot of this, fuzzy kind of improving health sort of stuff. I think the study's fairly good. The question is whether or not the jobs are really going to be generated. Conway's position is that'd be premature just to abolish the Medicaid expansion. Let's take a look at what happens. If we're supposed to go to a net negative in 2018 or 2020, whatever, well, deal with it then. One reason Conway wants to try to track the job creation and the income from it. There may be some sharp economists who can do that, but I haven't met them yet. Bevin would also abolish Connect and use the federal exchange. He says it's unnecessary duplicative. unnecessarily duplicative. One of the arguments against abolishing it is that, well, the feds charge 3.5% and the state charges 1%, but it's really apples and oranges. The state charges a 1% fee on every insurance policy sold in Kentucky. It's kind of a tax on insurance companies. It used to fund the high-risk pool, now it funds Connect. The federal charge of 3.5% is only for policies sold on the federal exchange. So, in effect, all Kentucky consumers are paying a little subsidy for Connect. Well, I've already been quoted in a publication as saying abolishing Connect would be pretty stupid, so I'll just repeat it. You know, we've got a program that works, a national model, as Conway and others said. He would keep it. The State Chamber of Commerce would keep it. Why Bevin wants to abolish it, I'm not sure. I think he's ideologically driven about these things, and it might be partly because the administration has branded all of Obamacare as Connect. They're trying to put a Kentucky brand on it. And it confuses things. You know, some people think, well, Connect is the Medicaid expansion. No. The Medicaid expansion is a separate thing, completely. You may enroll in Medicaid through Connect, but they're really two completely separate things. And maybe Bevin wants to do a frontal assault on Beshear's brand. It polls fairly well, but not all that well. Next issue. Bevin says smoking bans should be local, and Conway favors a statewide smoking ban. This is the one thing that Kentucky could do to have the greatest impact on its long-term health, in my opinion. You got 28% of the people in the state who are smoking. No wonder we lead the nation in cancer deaths. And it is, as Tom Birch alluded to, a legacy of our tobacco history. One thing you have to remember about tobacco. We used to have 50,000 or more tobacco farmers in this state. And they had a very good lobby. You know, their political, they were always a political issue, largely in Congress. So they organized very well. Now there are only 5,000 tobacco farmers in Kentucky. They really don't have that much political stick anymore. But it's still enough of a heritage kind of thing with the people in the Kentucky Farm Bureau, which is probably the most effective lobby in Frankfort, that it's difficult to pass a statewide smoking ban. And when you have Philip Morris or Altria Group spending $100,000 a year on lobbying, it makes it even harder. But if we could pass a statewide smoking ban, I think that you would show some effect on Kentucky's health status within 4 to 5 years, because it would make smoking inconvenient and more people would quit. Question?
I'm from a rural community, and I'm sorry. I'm Tierra Clark. I'm from a rural community in Marion County, Kentucky. So I realized that they put a ton of chemicals on the tobacco as they're growing it. And I'm told that they put a ton of chemicals in the cigarettes when they're manufactured. And the chemicals are, in fact, what's causing the health issues. How come we're not kind of paying attention to agriculture and the manufacturers instead of the ban?
Well, that's a whole other issue. And that really is a federal issue. I'm trying to keep this to state issues, but it's not an inconsiderable issue. And I'm glad you mentioned it. The cigarette companies will tell you that they monitor these things and that it's not that big a question, but I think the FDA might disagree. One more issue. Medical review panels for lawsuits against healthcare providers. This is essentially a battle between the providers and the trial lawyers. The House is Democratic. It's never given a hearing to this bill. The Senate is Republican. It likes it. And as you might expect, Bevin favors it, and tort reform generally, and Conway does not. But he says he is open to some other forms of tort reform. Well, that's a question for Conway if he comes to town. You don't like review panels? What other tort reform do you favor? Haven't seen anything to flesh out the detail on that. So aside from the governor's race, we've got much larger healthcare issues and health issues in this state. We have alluded to most of them, but I just want to give you a laundry list to show how bad it is. We do have a doctor shortage. A lot of them don't take Medicaid. A lot of people still don't know Medicaid is available. We're actually second in smoking. We go back and forth with West Virginia, and sometimes it depends on who's doing the survey, but suffice to say, we're one of the smokingest states, if not the most. 1/4 of people in Kentucky have tried electronic cigarettes. Teens' use of electronic cigarettes tripled last year nationally. And you can presume it's pretty much the same in the state. You see all these vape places. There are real health questions about electronic cigarettes. And, you know, again, an issue is what chemicals are in them. And a lot of people say, well, it's a good way to quit, and it may be for some people. But there's another study that shows that teens who use e-cigs are twice as likely to use tobacco after using the e-cigs. Number one in percentage of deaths from cancer. That's largely a function of tobacco, but not entirely. We're fifth in toothlessness. Oral health in this state is poor. Good reference for oral health stuff is the Kentucky Oral Health Coalition. It was reformed in the last few years. I had a part in doing that, and they're a really good source of information about oral health. And yes, gum disease can kill you. We're above average in diabetes and prediabetes. We're high in heart disease and obesity. And obesity is linked to lack of physical activity. Mental health, we rank poor. There are surveys done by the CDC constantly, and they ask people about bad mental health days or days where they felt depressed in the past month. And we rank fairly high in that, and we rank third in the percentage of people who take mind-altering drugs daily. That's what it says. That is a startling statistic. Well, lots of drugs have a mind-altering side effect, so we're not talking about opioids here entirely. It's a broad spectrum that may have some mental effect. I think that includes both prescribed and illegal. Luckily heroin use isn't that big, but it is increasing. And that's my next point, one of my last, because we do have the director of the National Institute on Drug Abuse coming. We cracked down on the pill mills, but people went to heroin, which, thanks to the Mexican cartel, is very cheap. Heroin's actually cheaper than cigarettes for users. Overdose deaths are up. And because heroin is largely ingested through the use of needles, hepatitis C cases are up. We are number one in the country in cases of hepatitis C, a state of 4.3 million people. So, if you want to find out more about these issues as it relates to your county, the Foundation's site, KentuckyHealthFacts.org, is a very good reference. And I hope all of you are reading Kentucky Health News. Well, did I miss that slide? There it is, Kentucky Health News. It's just kyhealthnews.blogspot.com. The reporter for Kentucky Health News is Melissa Patrick. Melissa, wave at the crowd. I'm very lucky to have Melissa, a former nurse, covering health. What we try to do is aggregate stories of interest to Kentuckians about health, and we do original stories about Kentucky health issues. And we do this with money from the foundation in an effort to get more health coverage into Kentucky news media, primarily newspapers, but we send them to broadcasters too, at least if the Broadcasters Association sends it along. I hope that those of you who are in a position to decide what goes into your news output, take a look at Kentucky Health News every week at least to see what's there, because I think we cover a lot of stuff that used to get covered by beat reporters at daily newspapers, but are no longer because those beats have largely disappeared. We're on the health beat in Kentucky in a way that no one else really is. Melissa's only part-time, but I spend a lot of time on it myself. And what we want to do is work with you to get more health coverage out there. We try each time in our weekly notice to give you something you can localize, because every newspaper in Kentucky is all about local news. Every broadcast outlet in Kentucky is primarily about local news. That's the reason your news operation exists. So there's plenty of local information available if you go to KentuckyHealthFacts.org, and there's current stuff available in Kentucky Health News, which is searchable. See the search box? Well, I've gone back 2 slides. I meant to do only one. The more stuff on a slide, the harder it is to deal with. I just have one more, but it's a quote that I think is worth repeating. Hasn't been uttered today, but the governor has repeated it more than once. There's a direct line from poor health to almost every core challenge Kentucky faces, whether that's poverty, unemployment, low education, substance abuse, or crime. There's a health element in it all. So why should you cover health? Because it matters to almost everything. So, questions? Feel like you've been drinking from a fire hose? John Cheeves.
You'd mentioned the creation of health industry jobs. You'd also shown the county-by-county level of people getting insurance. You'd never had it before. Has anybody looked at places like Harlan and Hazard where the coal industry jobs have all but disappeared, but the one institution they do have left is a hospital? And in theory, if suddenly a couple thousand local people now have insurance, maybe there's going to be an influx of dollars into the hospital because people can get medical care.
Sounds like a good story to me. Nobody's really looked at that at the local level yet. But the 7 Appalachian regional hospitals, one of which is in Harlan, would be a good case study. You know, has ARH increased its payroll? And what's that attributable to? It's real easy to talk and write about all these statistics, but unless you can localize it for your readers, listeners, and viewers, it's not really real to them. It's just 2-dimensional stuff on a slide. You got to have some kind of local element to bring it home. Other questions, comments, observations? Oh, Richard Heine of the Ferdell Committee for Health System Transformation has the pain of an unexpressed thought and hopefully a question. Richard, you have the microphone.
Well, it's not a question. My comment was...
it wouldn't be a question.
Yeah, thanks. My comment was about smoking. Al said that you would see a difference in 4 or 5 years. What's actually true is that you see a difference in the first year. In Lexington, when they passed the smoking ban, they had a 17% decrease in heart attacks the first year. And the same thing with asthma.
Right. What I'm talking about is long-term health status, but they really did have that much of an impact immediately. Mitchell from Channel 57 has a question.
Just a clarification on something here. You mentioned a study saying that this healthcare reform would pay for itself. This is the study that was commissioned by the Beshear administration, right? Okay.
State-funded study, Deloitte Consulting, LLC.
Hello, I'm Tisa Cunningham from Kentucky State University. I've heard a lot of people say a lot about the smoking ban, but not a lot about a tobacco ban. And that leaves a lot of room open for oral cancers with chewing tobacco. So are we going for a tobacco ban or a smoking ban?
There's not been any proposal to ban the use of non-smoking tobacco products, smokeless tobacco as they call it. But at the school level, 44 school districts in the state have anti-tobacco policies. And I think almost all of them ban the use of smokeless as well as cigarettes. So really the fight for protecting people from smokeless tobacco is largely a school district kind of fight. And that's something that is being considered by every single school district in the state that hadn't done it already. And that's not the kind of thing that's going to show up on your board meeting agenda. Don't cover the schools by covering the board meeting. You just use the board meeting as a window. There's always other stuff going on that probably gets decided even before it gets to the agenda. If your school district or school districts have not adopted an anti-tobacco policy, then the question is, why not? I'll bet you they've talked about it because they see lots of other school districts doing it. And it's fairly widespread across the state. It's just an interesting little pockets. And the most interesting thing is a number of those who've done it in the last year were prompted to do so by student requests. Students got together and said, we want to ban smoking in the school. And school boards were glad to have somebody to share the heat with them. And if people in the county complained about it, they can say, well, it's what the students want. We're trying to protect them. It's the perfect excuse or reason, really. We're trying to protect the kids and do what they want.
Hi, my name's Stephanie. I'm with the Messenger Inquirer in Owensboro, and I'm originally from Northern Kentucky and covered news up there right at the start of the heroin epidemic, and it's kind of the epicenter in the state, everything going on. It hasn't really come to Owensboro yet, but you hear people saying it's coming, it's going to be a. It's not to the level it is up in Northern Kentucky. How do you report on that, on people say, without over dramatizing it, without creating huge.
Don't be afraid to get ahead of what the public conversation is. Talk to some doctors. Talk to some people in the health field who will be, dealing with overdoses. Talk to law enforcement. They'll know if heroin's in town, and they'll know the extent of it. Be proactive on these things. Don't wait for it to come up at a city commission meeting.
Gabrielle Caldan with the foundation. A question about the use of the term ban. From a policy perspective, we're very careful not to ever say ban. It's a smoke-free policy. People can use tobacco, just not in certain areas. But I noticed that in the news, it's always called banning smoke ban, smoking ban, tobacco ban. Could you talk about the choice?
News media look for simple terms, and I'm sure that it displeases folks at the foundation who fund what we do that we use the term smoking ban too, because it's what people recognize and it's what people talk about. But we also try to use the synonym smoke-free ordinances or smoke-free laws to show that there is another way to talk about it. And that's how I suggest journalists do it. You have to use terms that people immediately understand, but you can also use the alternative terms, which don't sound so onerous. And that does reflect the point of view, but it's a legitimate point of view. So that's our thinking on it. One more question.
So, hi, I'm Elizabeth. I work for the University of Kentucky. I'm going to sort of springboard off the discussion of smoking ban. I cover the College of Nursing, which does a lot of smoke-free advocacy. A lot. Dr. Ellen Hahn and so forth. But they're now concerned about e-cigarettes and the sort of culture change that's occurring with the introduction of e-cigarettes and the advertisements for e-cigarettes. So this question is broader than the smoking issue, but e-cigarettes are sort of a new challenge. What are some new challenges in Kentucky that we're going to be seeing probably for the next 10 years? We know what we have in front of us. What do you think journalists and reporters need to be aware of what's going on?
Other than e-cigarettes? Yeah. Well, on e-cigarettes, that's just it starts out as a business story. If you have a smoking store or more than one crop up in your town, that's a story. Go talk to the people who open the business, talk to the people who go there to smoke. Why do they vape instead of smoke? Why do they vape and smoke? And there's plenty of research been reported on Kentucky Health News and elsewhere about the implications of electronic cigarettes. And you can do a good story about that. As far as other health issues coming down the pike, I feel like I'm drinking from the fire hose now. There's just a lot of stuff out there. All I can tell you is that Kentucky Health News will try to keep track of it. And one last question. No, I'm not going to take any comments. You had the floor a while ago, and we're over time, so we got to go. Thanks very much. Time for lunch.
Okay, quick point of housekeeping order. If you want to go through the front doors, please, for lunch. If you want to, excuse me. Okay, so just point of order, go through the front doors and get your lunches and come back the back. That'll be easier for the flow, okay? We'll take